All right, next we're going to talk about another very important electrolyte, which is calcium. So calcium is very abundant in the body. Drink your milk and then you'll have strong bones and stuff. And certainly that's where a large portion of our calcium is. It's a foundational component of our bone, but it's also important for other things such as cellular membrane stabilization, in addition to various physiologic reactions throughout the body. So an approximate range for calcium, total serum calcium is about 8.5 to 10 milligrams per deciliter. This varies a little bit on the source you look at, but the key here is that this is total serum calcium. And I mention that because if you look at our next bullet point, I said that calcium exists in two primary forms. We have the albumin-bound form and the ionized calcium, which is our active form. So when we measure calcium, we're measuring how much is in the body. However, what's active is the ionized form, sometimes also called free calcium. So the question you're probably asking yourself is why? Why do we have two different forms of calcium? And the answer lies in the fact that our physiology, our physiologic pH can actually change how much of the calcium is ionized versus how much is bound to albumin. So a couple points here. I said that free calcium or our ionized calcium is what exerts the physiologic effects in the body. So that's what can actually be used for the reactions that we need. But the reason that calcium is altered in terms of its ionized form versus its bound form is because of the pH and the hydrogen protons that are in the body. So if you draw your attention over here to this diagram, you can see that we have albumin, which is a very large negatively charged molecule at baseline, and our much smaller positively charged calcium. So in an alkalotic state, or one that has low protons, high protons would be an acidotic state, low protons would be an alkalotic state, we're going to get something that looks like this, where we have our giant albumin molecule that's negatively charged with our positive calcium. When there are low levels of protons, we have these negative charges available, where a positively charged calcium can then bind to the albumin. Remember, we've talked about the principles of magnetism before. A positive and negative charge are going to bind to each other versus like charges, a positive and a positive, or a negative and a negative are going to actually repel each other. So because of this, calcium will then bind to various albumin states, and that is going to create a higher percentage of albumin-bound calcium. This is non-active calcium. It would still be measured as part of our total serum, but it's not available to participate in our physiologic reactions. Let's compare this then to the opposite scenario where we have high levels of protons or a state of acidosis. And that would be our top diagram right here. You can see that when we have high levels of protons, they are positively charged as well, and so they will actually bind to the negatively charged albumin that I'm highlighting in blue over here. Because of this, you can appreciate that there's no place for the calcium to then bind to the albumin because the negatively charged binding sites have already been blocked by the high levels of protons or the acidosis in the body. This means that we will have a greater percentage of ionized or free calcium available to participate in physiologic reactions. So as you can see here, we talked about the total serum calcium being in this normal range, but sometimes this can be affected. If we have a low percentage of free active ionized calcium available, then even though we might have a total serum calcium that's within normal range, our ability to use that calcium could very well be limited, and thus we could actually get presentations of hypocalcemia because we don't have the active calcium that is available to do its work. Sometimes an important clinical skill is to be able to correct the calcium levels based on the amount of serum albumin. If a patient is very low on albumin, a protein in the body, if they have something like a nephrotic syndrome or cirrhosis, this could decrease the amount of total measured calcium in the body. However, it could not have any effect on the active physiologic ionized calcium that is available. So two key points to remember here when correcting calcium is that a normal albumin is approximately 3.4 to 5.4 grams per deciliter, and every point of albumin below 4, we need to add 0.8 to our calcium, because as we said, if our albumin is low for various pathologic reasons, this can potentially lead us to falsely believe that calcium is low overall. And so by using this correction method, we're essentially saying, is this patient truly in a hypocalcemic state, or is it just that their total serum calcium is low because they are low on proteins such as albumin? So first let's talk about hyperparathyroidism, and we'll start with the primary causes as we so often do. And one of the main primary causes is hyperparathyroidism. This should make sense to you all physiologically, right? Because what is the primary role of PTH or parathyroid hormone? It's to tell the body that it needs to release more calcium. So if you have hyperparathyroidism, that is, you have too much PTH, this is naturally going to cause an increase in calcium levels in the body. Another primary cause is sarcoidosis. And sarcoidosis is a common test question for something that causes hypercalcemia because it contains granulomatous macrophages that have an enzyme called 1-alpha hydroxylase. Higher levels of 1-alpha hydroxylase can actually cause an increase in the active form of vitamin D, and we know vitamin D plays an important role in kind of our calcium homeostasis and increased reabsorption of calcium throughout the body. Another primary cause is malignancy, and the reason is that malignant things, commonly a squamous cell carcinoma, can release something called PTHrP, which stands for parathyroid related peptide. And as you can imagine, this essentially has the same effect of PTH, which is our body's natural response to low calcium levels, our natural response to increase calcium. PTHrP is something that is released by a malignancy that is essentially a mimic of our natural PTH. So it is also going to work to increase calcium levels, and thus too much of this can cause hypercalcemia. Some secondary causes of high calcium levels include something called milk alkali syndrome. This is really not that common anymore, but historically patients could take something called calcium carbonate for stomach ulcers, and this can cause them to have a very elevated level of calcium in the body if they're taking too much in their supplementation. And finally, another cause is high levels of vitamin D. So we won't go over the pathway here, right? But high levels of vitamin D will lead to increased intestinal reabsorption of calcium. And so if you have way too much vitamin D, you can ultimately have way too much reabsorption of calcium. So next, let's move on to the presentation here. And you can see that the first thing I put is that it's often asymptomatic. And that is to say that high levels of calcium are often not noticed until we take routine labs on patients, until they get very, very elevated, sometimes needing to get above 12 milligrams per deciliter for us to really start seeing symptoms in a presentation in the patient externally. A common presentation that patients could have is recurrent kidney stones. So calcium obviously plays a role in the formation of various types of kidney stones. Our calcium oxalate stones are one of our more common ones. And so if we have higher levels of calcium, this is ultimately going to lead to a higher risk of developing these stones. So patients can have recurrent kidney stones. They can also present with polyuria or frequent urination. And the reason is that severely elevated levels of calcium can lead to ADH resistance, similar to the presentation of nephrogenic diabetes insipidus. And so remember, ADH, our antidiuretic hormone, is something that is secreted and used to reabsorb free water. If we have resistance to this molecule, aka we wipe it out, we lose our ability to reabsorb free water, and thus more of it will be excreted in the urine. And this is why patients will have a greater volume of fluid. Remember, ADH stands for antidiuretic hormone, and it's something that our body secretes so that we can reabsorb free water from the urine. Just a really quick review, when we think about our collecting duct from our nephron transporters chapter, ADH will go and bind to a receptor, and ultimately that is going to increase the amount of aquaporin channels and the ability to reabsorb free water so that it's not excreted in the urine. If we have resistance here and we block out the ability for this to respond to ADH, that is going to cause an increased amount of free water that ultimately gets excreted from the body, which I'm drawing here in orange. A very common memory aid that we use for a patient presenting with hypercalcemia is stones, bones, groans, and psychiatric overtones. Stones is referring to our kidney problems and our recurrent kidney stones being one of them. Bones is referring to bone pain that can present if we have high levels of PTH or PTHrP, and we're constantly reabsorbing bone in order to increase our calcium levels in the body. This can obviously cause some bone pain. Groans refers to the abdominal pain or the constipation that patients can endure if they have severely elevated levels of calcium. And finally, psychiatric overtones entails things that patients can present with if they have super high levels of calcium, such as anxiety or altered mental status. And finally, the management for high levels of calcium include treating the underlying cause, which is really always kind of our go-to thing for treatment of any electrolyte abnormality. It almost goes without saying, but here with hypercalcemia, it's kind of our main thing is to look for what's causing it. Is it a sarcoidosis? Is it a malignancy? Is it excessive intake? However, if the high levels of calcium is very severe, we would want to start talking about some other interventions that we could do to help the patient, such as giving intravenous normal saline. Why? Because we talked about how high levels of calcium can cause them to excrete free water, and thus they can become volume depleted very rapidly. And so it's important to replenish that volume so that we don't create another problem for them. We can also give them calcitonin. Remember, calcitonin essentially does the opposite of PTH. So it's saying tone it down for the calcium. It's causing more calcium to go back into the bone and decrease the amount that's in the serum. And finally, bisphosphonates is a group of medications that inhibit osteoclasts, right? So osteoclasts are our cells that consume bone. And if we are consuming bone, right, that's going to cause more calcium to be released into the serum, which is just going to further exacerbate the problem. So giving them a bisphosphonate is going to stop these osteoclasts from working, and thus it is going to decrease the amount of calcium that is being released from the bone by these osteoclast cells. Next, let's talk about low levels of calcium, the primary cause being hypoparathyroidism, right? This should start to make sense at this point. If we have low levels of PTH, we're going to have low levels of calcium because PTH is our primary hormone regulator of trying to increase calcium levels. Some of our secondary causes include low magnesium, and this is discussed in the magnesium electrolyte video as well, but very low levels of magnesium actually inhibits PTH release, and thus we can create a state of low calcium if we have inhibition of PTH release from another electrolyte. CKD can cause low levels of calcium because we do not have healthy kidneys, and thus we have a decreased ability to activate vitamin D because it's in our kidneys, specifically our PCT, which a reaction occurs that turns inactive vitamin D into active vitamin D. So if the kidneys aren't functioning properly, we are unable to perform this reaction. In pancreatitis, you can get something called saponification that occurs. And you don't need to know all the biochemistry behind this, but essentially the necrotic fatty acids can then bind to various electrolytes, such as calcium. And if they bind together, that is going to cause a decrease in the amount of free calcium in the body. And then finally, low levels of vitamin D is going to cause low levels of calcium because we've talked about how vitamin D is very important for our absorption of calcium in the GI tract. Our presentation here is going to be looking at some tetany, which are, again, irregular muscle spasms, seizures, and a prolonged QT interval. So remember, we talked about how calcium is very important in bone, and most of it is found in bone, but it's also very important in cellular membrane stabilization. So anytime you have a low amount of these stabilizing electrolytes, these stabilizing molecules, our membranes can essentially fire randomly or at inopportune times because they don't have enough of these stabilizing molecules around. There are two pretty classic physical exam findings that they'd like you all to know, and that includes Trousseau's sign and Vostek's sign. The first includes a hand spasm with inflation of the BP cuff. So essentially they'll talk about a patient who's getting their blood pressure taken, and you will notice, or in the question stem, they will tell you the patient's hand starts to essentially cramp up or spasm a little bit, and this is an indicator that they might have a low calcemic state. Another exam finding is this face spasm with tapping of the facial nerve. So this is saying that when the patient's facial nerve is palpated, it will cause a spasm reaction that will pull the mouth towards that area. It'll look something like this. And finally, to wrap up this video, we'll talk about the management. So we say that somebody has mild hypocalcemia if it's greater than 7.5, in which case you would just supplement that calcium, preferably by the oral route. PO stands for per os, which means that we're giving it orally. And if it's more severe, as in it's less than 7.5 milligrams per deciliter, you would give IV calcium gluconate. And this has in large part to do with the fact that we are trying to prevent cardiac abnormalities from occurring. These can be very serious and severe in a patient, and so calcium gluconate essentially works to stabilize the cardiac membrane so that we can prevent potentially very serious things from occurring. Additionally, you can also give them some vitamin D and magnesium. We talked about how vitamin D plays an important role in calcium homeostasis in terms of increasing our ability to reabsorb the calcium. So if somebody has low calcium levels, you can give them a vitamin D supplement. You can also give them a magnesium supplement because we said earlier that magnesium can have an inhibitory effect on PTH. So if their magnesium is low and they're unable to secrete PTH, they might continue to have a low calcium state if we don't also replenish their other electrolytes that are contributing to the problem.